Chennai. So on behalf of IAPTNSA, I welcome one and all. First, I will start with the pediatrician prayer, Dr. Gopal Subramani.
Good evening, one and all. We will start today's program with the pediatrician's prayer. குழந்தை மருத்துவனை நிறைஞ்சுதல் எங்களுக்கு முழுமையான குணமளிக்கும் திறனை தாரும் நோயின் துன்பத்திற்கும் திறன் நமக்கு வழங்கப்பட்டது எப்படிப்பட்ட சிறப்புரிமை என்பது பணிவுடன் நாம் உணர்வுமாக எல்லா குழந்தைகளுக்கும் அவர்களின் குடும்பத்தினருக்கும் அவர்களின் சமுதாயம் படிநிலை மற்றும் சாதி மத பிரிவுகளை பாராமல் நலம் கற்றல் ஈகை அன்பு அமைதி ஆகியவற்றின் தூதுவர்களாக என்றும் இருப்போமாக. நம்மால் முடிந்தவற்றை மாற்றவும் நல்லவற்றை உள்வாங்கவும் மாற்ற முடியாதவற்றை காரணத்துடன் ஏற்றுக்கொள்ளவும் போதுமான மெய்யறிவும் பொறுதலும் எங்களுக்கு வழங்குக. உங்களது வாழ்த்துக்களையும் அருளையும் கருணையும் எல்லா சூழல்களிலும் நேரங்களிலும் அனைத்து மக்களிடையே கொடுத்து அருளுங்கள். நன்றி.
Thank you, Dr. Gopal. Now I welcome our dynamic president, Dr. Ismail sir, to deliver presidential address.
Thank you, Raj and Gopal, and respected EB members of the Central EB members, Dr. Janani, Dr. Jalil Ahmad, and of course the CCB president, Dr. Venkatesh, and Amal, and all the faculty, today's faculty, Dr. Venkateswari, and all other delegates. Good evening to all of you. I think this program, we all know what is happening. And of course, hectic activity by IAPTNSC last week. We have completed about the 3 days of hectic nursing module. And after that, I think this is a continuous process. Of course, we are happy that Dr. Venkateswari has agreed to speak on this platform. We welcome you, ma'am, for this talk. And with these few words, I think let's go to the deliberations. Yes, Raj.
I request Dr. Venkateswari, consultant pediatrician, Kanji Kamakodi Child Trust Hospital, Chennai, to start the presentation for eating problems. Child is not eating. Okay. So I think it's a common problem we are encountering. And every mother, definitely in pediatrics, know that each and every mother that once in a lifetime, definitely they will tell this same answer, and we will repeatedly we are telling whatever we are know, and already literature wise as well as other things, we are definitely telling some answers. I think definitely we will tell that some definite answer today for this problem. Yeah.
A warm good evening to all the senior pediatricians, to few of my friends and colleagues who have spared their valuable time on this Saturday evening. At the outset, I would like to extend my gratitude and thanks to the IAPTNSC, the President, Secretary, and all the EB members for having given me this opportunity. When a movie starts, they always start with a slide saying that there is a disclaimer. Whatever is shown is not true, and we don't no animals were harmed during this movie making. So like that, when this particular topic was given to me by the EB member, Dr. Janani Shankar, everybody laughed because, as you all know, people who personally know me know that I am a person with a low BMI, and I have a 12-year-old son who's never crossed this third centile on the weight chart, on the growth chart. So Dr. Janani Shankar felt like I would be the apt person to do this topic. Over the next 40 minutes, I've tried to do some justice. I hope at the end of this talk, there are a few pearls for the primary care pediatricians from my lecture. In a busy pediatric OPD practice, I'm sure all of us will agree, we would love to see a well child. We would love to see a child who's come with some fever, because we are very keen to find out what is the focus of infection in this child. We are okay to see a developmentally abnormal child. We are okay if a mother comes and says, my child has poor growth. We all love vaccines and butter for a practicing pediatrician. And once in a while, we like to face challenges. So somebody comes with a very chronic ailment, we are happy to see them. But I'm sure all of you would agree, nobody is happy to see a mother or a grandmother or a family walking into your outpatient OPD saying that it is not eating. It is a nightmare for any pediatrician, from a senior pediatrician to just a budding pediatrician. We always find it very difficult to convince a family that even if the child is not eating, the child is fine and they don't have to worry. So in the next 40 minutes, my talk would be, I would just like to give an overview of what actually decides the eating habits in children, what actually decides your hunger and your satiety. And I would like to give a very basic stepwise approach to a busy practicing pediatrician. I'm not talking it from a point of view of a tertiary care setting. This is all really addressed towards a primary care pediatrician who's sitting in a very busy OP. And even in a very busy OP, as pediatricians, it is very important that we identify red flag signs. So any child who we might think that the child is not eating is just a normal thing. It is just a part of a behavioral pattern. But we need to identify red flag signs and we need to evaluate. I've also put a few very simple common case scenarios which we see in our OPD and how such case scenarios help us in our practice. So let me start with this slide. This is a complicated slide, but I've just put it to just let us know like the food intake in all of us is actually determined by the neuroendocrine feedback loop, which actually includes your adipose tissue, your gastrointestinal system, and your brain. So somebody feels hungry, the hunger signal goes, and then the person eats, and then he feels full, and then the satiety signal happens. None of us know why some people feel hungry all the time, and none of us know why for some people eat a few pieces of bread and then feel full. So the only thing that we all need to remember is ghrelin is the hormone which actually stimulates the hunger signal, and leptin plays a very important role in the satiety signal. The basic etiology, whenever a child walks into your OPD and the parents are concerned saying that their child is not eating, majority of the time, almost 90 to 95% of the time, we all know that this is possibly a non-organic cause. In my next 40 minutes, I'm only covering all these possible non-organic causes and a few scenarios of eating disorders. I've completely omitted the organic cause of eating, organic cause of not eating, because I'm sure all of us are very familiar with that systemic causes like your cardiac cause, your pulmonary cause, gastrointestinal causes, children with congenital malformations, children with achalasia, children with severe GER, children with hiatal hernia. The list is endless. So I'm only confining myself to discussion about non-organic causes and eating disorders resulting in poor eating in a child. There are numerous factors which actually influence food intake in children. The first and foremost in that would be the family environment. We all know that it is the family which plays a major role in shaping a child's future. So the eating behavior of the parent, the caregivers, and the elder siblings plays a major role in influencing the food intake in any child. Also, the exposure opportunities to new food, the opportunities to taste new food as early as infancy plays a major role. And we all know now with the availability and affordability of your junks, at the click of a button, we can get low cost, high caloric food. So the availability and affordability of food also plays a major role in our food intake. Previous food experience, suppose my child eats egg for the first time and then he pukes. So the next time, whenever you try to give him egg, the child is a little hesitant to take it. So previous food experience in the child always plays a major role in influencing his food intake in the future. And we all know, we don't have to talk about it, the strong influence of media in all forms. In all forms, your digital media, your social media, your print media, everything plays a major role in influencing food intake in children these days. So let me go through this short stepwise approach which we would follow in any child who comes where the mother says that her child is not eating. We always begin with the history. So let us assume that we just get a very short history. A mother says that a child is not eating. You get a very short history. You don't find anything really abnormal, no significant associated symptoms. All the mother is concerned is the child refuses food. So here the first step would be to actually assess the growth and development of this child. Always make sure that we use the standard approved growth charts, your WHO and your IAP growth charts to plot and to find out any red flag sign in that particular child. If it is a non-organic cause, we all know that the growth is not going to be affected. The child is going to grow fine. So the first step in approaching any child where the mother says that the child is not eating is to assess the growth. The major red flag signs in a child who's not eating would be poor growth. So any child who's less than the third centile on his weight or who's shown growth faltering in the last few visits, you find that the child is actually crossing 2 major percentiles. Then you know that there is something more serious that is happening in this child. So here you have to go in detail. We have identified red flags. This child has poor growth or this child has growth faltering. then I know I just can't start with a very simple history. I need to go into the details. I need to get a very detailed history. We are all familiar with a very detailed history taking in children. So we need to get through a complete detailed history. And in this day and age, history without the symptoms regarding the bowel bladder is absolutely incomplete. You have 10 children walking into your OPD, 8 have bowel bladder dysfunction. So we need to get a very detailed history about the bowel and bladder pattern in those children. And this is an era of the COVID pandemic where all the children are confined in their houses. They are locked in their houses. So we have so many children, even young children, walking in with lots of mental health issues. So a detailed psychosocial history is very important. Sometimes we will be taken by surprise. We have lots of parents who just don't come up with any significant history. And when you probe them, they casually say, yeah, 6 months back, my child had febrile seizure. And another doctor started my child on valproate. Now for the last few days, my child is not eating. My child has occasional vomiting. So they slowly come up with a history. And then you know that this could be something more than just not eating. So it is very important to get a detailed history whenever you have a suspicion of any organic cause. The next step, this is a very important step, the step which you can never skip, irrespective of your busy OP practice. All of us need to go through the complete detail of a very, very detailed dietary assessment. It all depends on the age of the child. If it is a young infant, then we need to ask the mother about breastfeeding, how long she exclusively breastfed, was she able to establish successful breastfeeding, or was she forced to give any milk substitute? If so, how did she give it? Did she give it via paladay or via bottle? When did she start complementary feeds? And then what happened to the milk? Did she continue the formula feeds, or when did she start cow's milk? All these things we need to go in detail. And we should never forget to ask about the intake of a child as a balanced diet as a whole. So we need to get a very detailed history about the consumption of fruits, vegetables, whole grains, water. This is a very, very important thing. When you ask any parent in your OPD these days, they casually say that their child hardly drinks water. So we need to remember to ask all the details when it comes to dietary assessment. And as the new term coined by our IAP, which includes your junk food and all your unhealthy, nutritious food, your caffeinated drinks, your sweetened beverages, we need to go through the entire list. And remember, we all come in a country where there are lots of cultural beliefs, there are lots of food fads. Even now, you can find plenty of families, however educated they are, they actually stare at you when you tell them you can give curd. They stare at you when you tell them you can give tender coconut water. So they have lots of food fads. They don't want their child to catch cold. They don't want their child to, they have lots of prejudices like it is hot food and cold food. So you need to go in depth and find out about the existing food fads in the family. And you need to ask about eating pattern of the family. This is a very important history which we all need to ask. Even amongst us, all of us at least eat once or twice outside these days. So it has become a very common thing. So gone are the days when we used to go to restaurants once in 6 months or once in a year. Now almost every family orders food or eats outside. So we need to find out what is the eating pattern of the family members. What do the parents do? How do they eat? Do they eat lots of junk food? All these things are very, very important. So the first step is growth assessment, and the next step would be a very detailed dietary assessment. The step 3 would be an examination. We all are very familiar in a busy OP practice. We are very quick enough to do a quick head to foot examination, not to miss some certain very important findings. And I'm sure all of us are very good in picking up red flag signs. I'm not going in detail into the red flag signs because I'm not going to touch the organic causes. So any of the red flag signs will mean that this child has an organic cause. Whereas it is very common to miss a very mild iron deficiency anemia who's on predominant milk feeds. A mother might not notice that the child has an oral ulcer unless the child has complaints of difficulty in swallowing or child has drooling of saliva. The mother might have missed the oral ulcer. The child would have played with a pen and would have injured his oral cavity and traumatized his oral cavity and might be refusing feeds. So some transient causes, if the mother says my child was perfectly fine last week, but today she's not eating, we'll have to definitely look into the oral cavity, look into the throat, and look for all these things. And these days, most of the parents are working. Anytime you ask them, what is your child's bowel pattern? They say, oh no, she's fine. But nobody has gone into the toilet to see what's happening to the child's bowel movements. And then you will be completely surprised that when you examine the child, you find masses, you find lumps, you find fecal masses. So it is very common to find mild pallor. It is very common to find a child who's constipated when a mother comes and says that my child is not eating. So these are the 3 steps which are very important in evaluating, in assessing any child who walks into your OP where the mother is concerned about not eating. The fourth step will be evaluation. As I told you, 90 to 95% of the time, we know that this is a non-organic cause, and all we need to do is just counsel the mother. We just need to talk, and talk. Evaluation is not routinely needed in any child who's not eating well. So unless you find red flag signs, unless you think that the child has a poor growth, you want to rule out some organic cause, you can go ahead with some baseline evaluation. And depending on your clinical findings, suppose you find you're suspecting that this child has lost weight, has systemic symptoms, has fever, has some contact history, then you go ahead and do a tuberculin skin test, your X-ray, and proceed with your tuberculosis evaluation. Suppose you're suspecting a severe GERD, then you go ahead and do your gastro evaluation. So don't jump and do a head-to-foot full system evaluation in any child who comes with a complaint of not eating. It is definitely not needed. So I'll go through a few simple case scenarios which will actually tell us the common problems which we face whenever a child comes with a complaint of not eating. The first scenario will be a 10-month-old infant. The mother has actually brought the baby for the 10 months vaccination, but then she's sitting on your head saying that my baby doesn't eat. Whenever I try to force feed my baby, maybe just vomits. But then you find the child is growing normally, and on examination, you find a very happy, a well-nourished child, and you don't find any red flag symptoms or signs. So then now we go to step 2. We actually go through a very detailed dietary assessment, and we ask the mother what's happening to the diet pattern of this infant. And there you find that there are lots of flaws in the diet pattern of this infant. The mother says that she had a tough time in establishing breastfeeds, and she was not able to continue breastfeeds after 2 months of age, and she was forced to switch over to milk substitutes. Since 2 months of age, the baby has been on bottle feeds, and the family introduced complementary feeds as early as 5.5 months of age. And when you ask her what kind of kanji, is the child on mashed feeds, this, that, the mother says, my baby refuses home cooked food and prefers to eat the commercially available formula feeds and prefers to eat all commercially available cereals. When you ask the mother what happened, are you not aware of the feeding pattern in infants? What about your vaccination visit? Did your pediatrician not talk to you whenever you went for a vaccination visit? The mother is not sure whether her pediatrician told her in detail about the feeding pattern in infants. And to add more to the fuel, the grandparents have lots of concerns about giving certain home cooked foods. The grandmother feels that she should not give ragi. Other person feels that they should not give curd. So there are lots of food facts in the family. So here you find that this baby does not have an organic cause. This baby is perfectly fine. This baby is growing normally, developmentally normal. But here this baby has lots of problems only with the diet pattern. So we know very clear that all we need to do in this baby is this baby does not need an evaluation. We need to spend at least 5 to 10 minutes in reassuring the mother and counseling the mother regarding the diet and feeding pattern which is normally seen in infants. So we all should remember, but this is something which all of us miss. We miss the boat and then we suffer because we don't do this particular thing. Preventive nutrition counseling during all the well baby and vaccination visits. When a baby comes for the first vaccination at 45 days, then the baby comes for the next visit and the third visit, it is very, very imperative. Actually, we all know, we've just finished our breastfeeding week. We all know that counseling regarding breastfeeding and the problems which the mother can face and during establishment of breastfeeding should be started antenatally. So we start antenatally, the pediatricians have to be involved antenatally, and then postnatally, it is very imperative that during every well baby and vaccination visit, we pediatricians go through the entire pattern again. We ask the mother about the breastfeeding, whether the baby is hungry, whether the baby is finds that the milk output is adequate. How does the mother think whether is she able to successfully breastfeed a baby? When the mother comes for her third vaccination, in this day and age, most of the mothers are working. As pediatricians, it is very important that we talk to her and ask her what is the plan about getting back to work. How long is her maternity leave? What has she planned about breastfeeding? We should encourage her to continue breastfeeds. We should counsel her regarding the complementary feeds. We should support her in all possible ways. We should also counsel the family members. It is very important that we talk to the family members because in India, it is the family which raises a child and not the mother alone. So as a busy practicing pediatricians, I always think it is very easy if we have printouts, if we have paper books like this, where you have all the details about the complementary feeding guidelines. All this is available. We have clear-cut guidelines from the WHO as well as the IAP regarding when to start complementary feeds, what type of food are we supposed to start, what is the consistency, This particular guideline tells you in detail about to start with cereals and then add pulses, to start with mashed form, go to semi-solid form, and then go to solid forms. It tells you about finger food. It tells you about when to switch over to spoon feeds and when the child can actually self-feed. It also gives you options of what all available home cooked foods can be used in starting in a child who's supposed to be started on complementary feeds. So whenever a mother comes into our OP, it has become normal these days for a mother to ask us, "Doctor, can you please give us a diet chart? Doctor, can you please tell me what to feed?" Because they're confused. They think like all the commercially available cereals are good. They are bombarded with too many advertisements. So the mother is absolutely confused. You might think that she's an educated mother. You might get angry for her to asking for a diet chart. But this is the reality these days. So it is very easy when we give them a pamphlet like this. The mother is educated. She goes through everything and she can always read the paper in your OPD, and she can get back to you if she has any queries. So in this first case scenario, the learning lesson would be it is very, very imperative that we do a preventive nutritional counseling during all the well baby as well as the vaccination visits. We'll move on to the next case scenario. Here we have a terrible 30-month-old toddler who is actually walking into your OPD, who is running and coming to your OPD, but the mother keeps a very small face. She's very unhappy. You ask her why she is unhappy. She says, "This fellow does not eat. And then this fellow looks very small. Everybody in my family is mocking at me. They say that I'm not feeding him well. They feel like compared to all the other children in the apartment, my baby looks very small." And then you ask a detailed history. You know this baby is going to be constipated. You ask that history, and then the mother says, "Yes, doctor, you're right. He refuses to pass stools. Whenever he feels like passing stools, he runs and comes and sits on my lap. He does not pass stools." But you plot him on the growth chart. You know that he's growing well. You know he's on the 10th centile or the 25th centile. You're not worried about his growth. And clinically, you know that this child has pallor. This child has nutritional anemia, and a constipated child, you find that there are fecal lumps when you palpate him per abdomen. So here this mother does not even have to tell you what is the diet pattern. We can just tell out what is going to be the diet pattern in this toddler. So here is a toddler who's been only predominantly fed with bottle, that too with milk feed. You actually shout at the mother saying that it's all your fault because you were only giving your child bottle feed and that too milk feed. And the mother says, "It is not my fault. It is because my child is not eating, I'm forced to give him milk." So this is just a vicious cycle. We blame the mother and the mother blames the child. So here we need to be patient. We need to clearly explain the mother the effects of bottle feed, the effects of giving a predominant milk-based diet, and how it can actually affect the nutritional status of the baby. And then the mother very proudly says, "My child never has a feed without watching any mobile. He loves to watch cartoons during feeds." And then when you ask, this is a 30-month-old, so you presume this mother is off, the baby is off breastfeeds, but the mother says, "No, doctor, he's just not letting me go. Occasionally at night, I still breastfeed him." And you ask him, "Does he self-feed?" The mother says, "No, I have to be behind him. I have to put all the food inside his mouth. He never self-feeds. He's too energetic. He gets easily distracted and he hardly takes fruits and vegetables." So here we know we are talking about a toddler, the terrible twos, where a meal time can become a war time for the entire family. So these are some very, very important physiological things which we all need to understand about toddlers, and which we all need to talk about and tell mothers about whenever they come with a toddler who is not eating. We all need to explain it to the mother that toddlers they generally have a very slow growth velocity. So because of this very slow growth velocity, there is this physiological anorexia. The child does not have to eat much, then the child automatically has some physiological anorexia. So the child eats enough to just grow, to just make up for this slow growth velocity. And toddler period is a time when the child actually has to struggle for autonomy. So here is the time when the child wants to self-feed. The child wants to self-feed, but the mother doesn't let the child self-feed because he spills all over. He eats only a few pieces and lives behind. So the mother tries to put everything in his mouth. The child becomes very annoyed and he actually refuses his feeds. And the toddler is somebody who loves to explore the environment. So he gets very easily distracted. So feeding time should never be distractible time. So the child should be off mobiles, off tabs, off laptops, off screens, off any screen, in even books. So nothing should be available when the child is feeding. Feeding time should only be feeding time. And we all know that toddlers are actually neophobic. You give them a new food, they hate it. So all these are very important physiological things that we need to understand and that we need to explain to a mother who's got a toddler who is refusing to feed. So in this particular child, we know unless we are going to stop the bottle feed and wean the child from breastfeed, this baby's appetite is not going to improve. So we need to spend a little extra time. We all are very familiar. We like to say the word white poison. We can use the term just to put it into the mother's head to say like milk is too much of milk is is not good for the child and it's going to make the child nutritionally deficient. So here we have to explain to them a child does not need more than 600 ml of milk per day. And it is imperative that the mother does not have to continue breastfeed for such a long time. And unless we treat the constipation and iron deficiency anemia in this child is not going to eat well. So we have identified a problem secondary to poor feeding in this child, secondary to feeding of too much milk in this child. So we need to treat that. So we need to treat the constipation and we need to treat the iron deficiency anemia. We need to patiently explain the mother that this baby is struggling for autonomy. So this baby needs to be given a choice to self-feed. So we need to explain to the mother the transition that happens when a child can start spoon feeding and when a child can start self-feeding. So here we have to encourage the mother to self-feed the child and not be behind the child to feed. We have to tell the mother to make the child sit along with her whenever she feeds, and the child can feed on his own and the mother can eat on her own. And absolutely no distraction. So we need to tell a definite no to all gadgets as well as books whenever a child is feeding. Even you tell all these things, the mother still has lots of concerns. So we can say a few more extra points. You can always say, don't start with a very large portion on the plate. It is natural for some grandparents to keep a huge amount of food on the plate. So thinking that the child is going to eat everything. The moment the child sees it, the child feels completely satiety. So you have to tell them, make the child eat only when the child feels hungry, and start with small portions on the plate and allow the child to ask for repeat whenever the child finishes, soon after the child finishes. And the mother has to refrain herself from criticizing the child based on the food intake. And we have to reassure the mother that this is a physiological anorexia and the food consumption in this particular child is actually matching the slower growth rate. And these are neophobic toddlers. So mother should not think, I'm trying multiple new foods, but my child is just refusing to eat. Here you have to tell the mother, like, any new food should be given at least 8 to 10 times for your toddler to gain acceptance. So all these are very important points which we have to go through and explain to the mother in detail. There is a classification of feeding disorders in infancy and early childhood, where you can have feeding disorders due to a dysregulation state. You can have feeding disorders when there is a discrepancy between the caregiver and the infant reciprocation. And there are two very important things where you have infantile anorexia and sensory food aversion. And your fifth one is your post-traumatic feeding disorder. These things are more of theoretical, but all these 5 feeding disorders, we need to remember, they cause some growth failure in a child. So they are not the normal non-organic cause. Here is when a child has these problems and you have done an extensive evaluation, you've ruled out all the organic systemic causes, you know that this child has a particular feeding disorder and needs more help. Infantile anorexia usually occurs between 6 months and 3 years of age. It's a very important point to note here is it shows significant growth deficiency. And your sensory food aversion, this was a term which I was not really familiar with. When I spoke to our gastroenterologist, he said like gastroenterology people see this particular type of food aversion quite commonly, and these children are very difficult to manage. The child refuses to eat specific foods with the specific tastes and textures and smells and appearance. So the parents have a very tough time managing these children. And the management is usually to give the child whatever the child prefers to eat. And these children are actually at risk for nutritional deficiencies. We'll move on to the next case scenario. Here we have a 5-year-old boy. The mother is very concerned only about one thing. She says, my child has always been a slow grower. He's always been on his 3rd centile. There is never a time ever since infancy, whenever you plot the growth chart, my child has been on the 3rd centile and has never gone above the 3rd centile. So compared to his peers, he's always been a very slow grower. However, there are no associated symptoms or any other red flags. And when you plot him on the growth chart, you know that the mother is right. The child's weight is on the 3rd centile. His height is okay. It is on the 10th centile. And your systemic examination, your general and focus examination is normal. But then you go into your step 2, where you get a very detailed dietary history. the mother throws the diagnosis at your face. Here is a child who just does not have any interest to eat food. This particular lack of interest to food is for both familiar and unfamiliar foods. Even if you give him some food which he is familiar with, he actually accepts only a very limited amount. He eats very small amounts and he is unwilling to try new type of foods. He has very strong food preferences, and vegetables is a strict no-no for this particular child. So this is one scenario which all of us dread of. Here is a picky eater, which is a nightmare for the entire family as well as for the pediatrician, for the primary care pediatrician. Picky eater, I was very surprised. There is no term called picky eater in any of our standard textbooks, but the term picky eater is used in almost all the majority of the journals. So there are lots and lots of, I found around 125 studies on picky eating in children. So it comes under the classification of a behavioral eating disorder. It is quite common in toddlers and preschoolers, and as the child grows, they all get better. There is no universally accepted definition or an assessment tool to identify a picky eater. And the importance, why do people do so much study on a picky eating child? It is because we all know that a picky eater causes so much of stress to the parents, and it ends up having a negative impact on the family relationships. So there are lots of long-term studies where they've actually followed up these picky eaters to find out what happens to their growth. But majority of the studies shows that they all are around the 50th centile during their later years. So the study on the growth trajectory is actually quite reassuring. However, a few handful of studies have shown that these children may be at risk of being thin during their adolescence, or they may later emerge as an eating disorder. However, these are only a few studies. Majority of the studies shows that they actually they're okay, they do well on their growth, and all they need is just reassurance. Can we predict that whether this particular child can turn out to be a picky eater later? There are quite a few studies where they have tried to find out whether there is any antecedent for a picky eating behavior in younger children. And there is one particular study where they found like infants who have early feeding difficulty and who were introduced late to lumpy foods and who are subjected to too much of parental pressure to eat. All these three factors influenced, and they turned out to be picky eaters later. Management of picky eaters is like any other not eating child, but it is very difficult to convince a mother who is of a picky eating child because she is left with very minimal options. Here is a child who just does not who lacks interest in food, who is happy to have a very small amount of food and run away. So we need to tell the mother, we need to plot the growth chart, we need to reassure the mother saying that in spite of all his picky eating habits, this child is growing well. This child, even if he is on the 3rd centile, he is still okay. He doesn't have any red flag symptom or sign. So we need to first reassure the mother who, even recently we had a mother who walked into our OP. The mother had a picky eater. The mother just started crying unconsolably because she was under too much pressure from her in-laws and everyone else. Our society puts so much pressure on the family as well as the parents when a child is a picky eater. So we need to reassure the mother. We need to spend a little extra time, and we need to tell her a few tips. We need to tell her that she needs to build comfort and familiarity with the food. So she can actually take the child to shopping with her. When she goes to the market, she can take the child with her. She can actually involve the child in cooking. She can actually involve the child in gardening. She can create positive memories and experiences around food. And most of the picky eaters, after repeated exposures, they start accepting that particular food. So we have to tell the mother all these small things which can actually improve the appetite in her child, which can actually improve the food intake in her child. And we should always tell her, never use food as a reward. Obviously, a picky eater is not going to accept the food as a reward. She can use non-food rewards for motivating the child to eat something. So this is in simple a management of a picky eater. Is there a role of appetite stimulant? We know. Satya tonic, doctor, please give something which will improve my child's appetite. We always used to make fun in our OP when a mother asked this. I used to tell her, Amma, நீங்க ஏதாவது கண்டுபிடிச்சீங்கன்னா எங்களுக்கு தயவு செய்து கொடுங்க, நாங்க எல்லாருக்கும் அதை கொடுத்துடுறோம். So we all know that we don't have a magic drug to improve appetite in all these picky eaters. However, there are a few practitioners and gastroenterology people in particular are very comfortable using appetite stimulants. The commonly used appetite stimulant is a cyproheptadine. All of us know that it has antihistamine and antiserotonergic property, and the major side effect is actually your CNS side effect, which is your drowsiness, irritability, excessive sleepiness. I couldn't find, and I think there are no definite recommendations or guidelines for use of any appetite stimulant in a child, especially a picky eater. So we should remember that we should not write an appetite stimulant just for the sake of allaying a parent's anxiety. What about multivitamins, our famous Satutonic? This is natural for a mother or a grandmother to ask you this question. This child is so picky. This child doesn't eat anything. I'm sure this child is deficient in iron. This child is deficient in zinc. This child is deficient in all the vitamins. Please give a multivitamin syrup, doctor. So we need to know, just writing a multivitamin syrup does not solve the problem. When you write a multivitamin syrup, we actually give a false impression to the family that this child's diet is complete. The focus shifts from actually giving the recommended food with required all vitamins as food, because the family feels, okay, anyway, this child is on multivitamin supplements. The only indication where we actually put multivitamin in a child is when you know that this child is on a particular diet that may be poor in one or more nutrients. So when you are very sure that this child is going to be nutritionally deficient in this particular diet, then you can supplement with that particular nutrient. If you have a child who has a chronic ailment that puts him at risk for deficiency, then you can put them on multivitamins. However, there is absolutely no role for multivitamins in just a child who's otherwise well, who's growing normally, but who's just a picky eater, and only the parents are concerned, but the child is not nutritionally deficient. We'll move on to the fourth scenario. This is a very common scenario. Here, it's actually the mother who needs therapy and not the child. A 14-year-old girl, adolescent girl, walks into your OP. One look at the child, you know, it is very common these days to find 14, 15-year-olds weighing 70 kgs or 75 kgs. And one look, you can see that they have acanthosis nigricans. You plot them on their growth chart, they have a very high BMI. But the mother says, no, doctor, she just doesn't eat. And you feel like screaming at the mother. How can you say that this child is not eating? But then the mother says, no, you try giving her idli, you try giving her, she just doesn't eat. Then you ask the mother, what happens? I know what your child eats. Then the mother says, when does she get up? She gets up just 5 minutes before her class. She sleeps very late in the night. She's very busy with all the gadgets. She goes to sleep late and she wakes up very early. She skips the breakfast and she snacks. She grazes around and she keeps eating all the junk food during online classes. She loves eating fast foods. Vegetable is never in her list of food that she eats. And fruits, she just does not love fruits, but she prefers fruit juices and milkshakes. And mother has no idea which diet is high in fiber. So this is a very, very common scenario these days, and almost all of us are familiar with this. It is a pain because we have all working parents so the parents themselves in the morning, they're not in a hurry, they're all in a hurry. So they eat ready to eat food, they eat ready to eat cereals, and there is absolutely no time. Everyone is running. So the schools are closed, the playgrounds are closed. So there is absolute lack of physical activity. The children are stuck to gadgets in the name of online classes. There is absolutely no sleep hygiene. Almost every child who walks in now says that she feels sad or she feels depressed or anxious about her exams. And every child has a gadget. Even if the parents are not there, the child can actually ask for any food she wants using her food delivery apps, and all the eating habits has got haywire. So this is it is a very important thing in any adolescent who comes into our OP for something else. The child comes to you for something else. The child comes for a headache. The child comes for some other complaint. It is very important that we catch them early. We talk to them. We can have this My Plate chart in all our OPs, in all our clinics, so that we can even ask our staff nurse or the receptionist or any non-medical person. It is very easy for them to understand this My Plate chart. Somebody has to explain it to the family as well as the child, tell them the importance of eating a very balanced diet. Recently, IAP has come out with a very good parental guideline on junk food. We can give a printout of those guidelines. And most importantly, we need to tell the parents that they have to eat healthy. If the parent eats pizza and burgers and they expect their child not to eat it, that is not right. The parents have to be role models. And we need to tell the parents about having at least twice or thrice some scheduled family meals sitting at the table. Gone are the days when the family used to sit at the table and eat together. Even in our homes, those things don't happen these days. So it is very natural that everybody is running around and everybody is eating alone. So we need to explain to them about the importance of having a regular scheduled family meals. And we can always tell the mother, almost all our children hate vegetables. So when your child is hungry and sitting at the table asking for food, please offer them vegetables first. Let them eat the vegetables first, and then you can give them whatever is their favorite food. So these are things which we need to go through, which we need to explain to the parents. These are part of preventive nutrition counseling, and we need to explain it to every adolescent who walks into our OP. This is my last case scenario. Here you have a 16-year-old adolescent girl. This child is a very classic child with an eating disorder. One look at this slide, you know that this is trouble. So here is a child who is gets sick, who has a very low BMI. She's undernourished and stunted. But then the child says, no, I'm fine. I'm eating fine. But then when you ask the mother says she just avoids food. But the child keeps saying that she's eating enough. And occasionally she feels that she's eaten a little too much and she goes and self-induces vomiting. And she's not been having her menstrual cycles for the last 4-5 months. So here the diagnosis is very striking. This is possible anorexia nervosa, which is a very severe eating disorder that can happen in adolescents. And in this day and age where mental health issues are getting more common in children, we need to be aware of this particular condition. So eating disorders in older children and in adolescents, there are 5: anorexia, bulimia, your binge eating disorder, your avoidant or restrictive food eating disorder, and your not otherwise specified eating disorders. Why is it very important to identify eating disorder? Because this is dangerous. These children can develop severe complications. So we need to identify the red flag symptom. The red flag symptom here will be definite documented weight loss. So the child has crossed the percentiles. So you know here is a child who has a problem. And before we send the child to a psychiatrist, we have to be doubly sure that we have done a detailed evaluation to rule out all possible organic causes of weight loss in this particular child. And once we confirm that there is no underlying organic cause, this is more in favor of an eating disorder, we involve the psychiatrist as the primary person along with a multidisciplinary team. And the child might even need some medications, and the child takes a very long time to recover. So let me finish my talk with a few tips for the parents as well as for the pediatricians. So we need to tell the parents, never force feed your child. So never force feed your child. Children hate that. And you have to be a role model for your child. You cannot eat junk food and you can't ask your child to eat a fruit. So you eat a fruit, your child automatically starts eating a fruit. And please have scheduled family meals. A meal with the family is such a pleasurable experience for a child. And always promote home cooked foods and avoid getting foods frequently from outside restaurants. And even in home cooked foods, you need to make sure that for younger children, you need to make that there is variety within each food group, because it is very easy to make idli in the morning. You can't put the idli 5 days in a week. Even as adults, we find it very boring. So they need to have some variety within the same food group. Some children, if they're very picky, you can actually get them interested. You can actually make different shapes of dosas. Here is an example of a shape of a dosa with like a bird, and the mother has put some carrot on it. So this makes the child accept the food more easily. So you can give it more colorfully, and always involve your child in while you're preparing the food process, because it creates a more positive experience in the children. And the most important of all, let your child play, let your child exercise. That is one thing which is going to stimulate their hunger. So we need to tell the parents, please send your children out to play. That is very, very important. So the pearls for practicing pediatricians would be, don't be judgmental. It is very natural for all of us to be judgmental when a mother walks in and says, my child is not eating. We just lose our temper. We just get angry. We try to find all possible fault with the mother, with the family, as well as with the environment. So let us not be judgmental. Let's be more empathetic, because we are practicing in a setup where there is a huge cultural and family influence on when you bring up a child. So we all have personally gone through that. So it is very important that as pediatricians, we should not be judgmental. And a basic history and a clear stepwise examination is very important. Though we know that around 90 to 95% of the time, it is not an organic cause. We should be extremely careful not to miss an organic cause when a mother comes and says that her child is not eating. And we need to remember, preventive nutrition counseling is a very important aspect of anticipatory guidance. Like how we say when a child grows up, we say your child will start exploring the environment. Be careful with toys. Be careful not to give food which will choke. As we provide anticipatory guidance for all other aspects of development, it is very important that we start early. We start antenatally your preventive nutrition counseling. And at every different stages of the child's life, we need to provide the family preventive nutrition counseling. And it is very easy in a busy OP when you have your prepared handouts. regarding your exclusive breastfeeding, the advantages of breastfeeding, the principles in introducing complementary feeds, and your parental guidelines regarding junks. All these handouts will go a long way in helping you in running your OPD without any major hassles. And last most important thing, growth assessment. Please plot growth charts. Please make it a point to plot a growth chart at least once in 3 months. And always remember, a visual image of a normal growth pattern will convince even a very difficult mother. A mother is so unhappy that the child is not growing, the child is small. But here is a visual image which says that this child's growth pattern is turning out to be normal. So this is very important. So this will be my pearls for the practicing pediatricians. Let me conclude my talk by saying this favorite saying from Hutchison, which I love a lot. So from inability to let well alone, from too much zeal for what is new and contempt for what is old, from putting knowledge before wisdom, science before art, and cleverness before common sense, from treating patients as cases, from making the cure of a disease more grievous than its endurance, the good Lord should deliver us. Thank you all. I once again thank all the members of the IAP TNSC for giving me this wonderful opportunity. And I thank all the delegates for sparing their time on this busy Saturday evening. Thank you, one and all.
I think she needs a clap. It was amazing. It was really good.
I do agree with Dr. Janani. I think Janani told me you log in and see how she's going to talk. But really, I was happy. I was just pondering actually this topic when we were chosen. Actually, my granny had 12 children. All those children, those time it was poverty. So I don't think people had this eating problem in those times or those years, because really for want of food, the children were greedy to take the food those days. But now a lot of abundance and a lot of people, everything is being provided to the kid now, and a lot of exposure. I think that makes the thing more worse, and the children are slowly changing into this picky eating and so many other things, junk foods, everything is disturbing them, and the entire scenario is getting disturbed, and especially mothers are all overstressed. Every other day, every third mother comes to you, sits with that thing. She wanted definitely a tonic or a medicine which makes the child eat. That is the biggest problem for a pediatrician now. And I think Dr. Venkateswari, you have done a great job sensitizing all the pediatricians, especially that about the picky eaters. You are very honesty to say, I think you have done a wonderful job actually clearing all the pediatricians' minds, I think, how to counsel the parents. And especially I love all the way you are directing the case scenarios, especially choosing one scenario, and it is really very informative. I thanks for your wonderful preparation, and as well it's deliberating in a nice way. Thank you.
Thank you, sir. Thank you so much.
I think.
Comment?
Yes, sir. Jalil, sir.
Wonderful, Dr. Venkateswari. You started with the growth chart, that is growth evaluation, examination, and you insist on there is no need for evaluation. And you have also already mentioned about the case scenarios. I think my personal request on behalf of IAP, you have mentioned about the handouts. We should have 3 handouts like breastfeeding, complementary feeding, and junks. If you come out with the handouts so that it could be uniform, so that we will have.
Sure, sir. I can do that, sir.
Handouts is very, because I'm lacking, as you presented in the slide, the slides are very good. And many patients, they are asking for a, sir, food chart irkuda, food chart irkuda. I'm practice panda rendu hospital, we don't have a food chart. The handout, if you can make out, and I request Ismail also to take care.
Yes, Dr. Venkateswari, we would love to have such one. I think IAP TNSC can just design it, and then we can send it to all the practicing pediatricians throughout the state.
Sure, sure.
Wonderful talk.
Thank you.
Sure.
Someone
Now,
has
I think
asked about
Dr.
lysine.
Ismail sir will agree that she'll make it interesting.
Yes. 100%.
One thing with Venkateswari is any topic you give, she'll try to make justice to that.
She is inversely proportional, madam.
That's true.
She started with the BMI.
Subjected to intense ragging for the last 2 days because of this topic.
Every day. Last time also we had a wonderful talk by Dr. Geetanjali. This time also nice. And another 2 more person has to go. Anyway, congratulations to Dr. Janani and Dr. Venkatesh sir and all the IAP teams. Good.
Amal is there? Questions?
Amal, yeah, Amal, your comments.
Yes, sir. It was an excellent talk by Dr. Venkateswari madam. Actually, she steals the show. I think there are no questions. I think this is the
All
first North
appreciations.
Zone CME where there is no questions. I think she has really done a wonderful talk and she has cleared all the doubts, I think.
Yeah.
In fact, there were a lot of learning points for a lot of practicing pediatricians.
Yes, yes,
Amal,
yes.
there is one question using lysine.
Yeah.
Your take on that?
Yes, sir, I saw that, but actually I couldn't find any definite recommendations or guidelines in any of the standard textbooks when it comes to your multivitamin supplements or any supplementation for that matter. I personally spoke to our gastroenterology person just to find out if there are guidelines. I believe there are a few guidelines among the specialty people where they have a very challenging child, suppose a child with a sensory aversion problem, a child with some problem, where they actually use as appetite stimulants, they actually supplement the child if the child is lacking in anything. But otherwise, from a general pediatrician point of view, I don't think there are any standard guidelines to tell that you give this particular supplement or you give this particular stimulant, the child is going to eat better or it is going to help the child.
Thank you, doctor. Thank you.
Any other, Dr. Venkatesh, you want to say something?
No, yes, this is an excellent talk by Dr. Venkateswari. It actually has really given a stepwise approach to the common problem faced by all practicing pediatricians in private practice. It's a daily scenario. So it's really very good talk. And congratulations to her and also to the TNSC team for giving a really good topic for.
Hope the topic we selected is justifiable, sir.
Yeah, the topic was really useful. It is really a point for the primary pediatricians. It's a bread and butter actually. This topic is.
Okay, sir. Okay.
Thank you.
Thank you very much.
Thank you. Thank you all.
Thanks,
Thank you all.
Venkatesh, Venki, for making it very interesting. I think about 81 people have logged in on a busy Saturday
84,
evening.
madam.
84, I saw.
84, when there are
close to
so
84.
many other parallel programs that are going
Yes.
on. So I think we should give her a big hand and conclude.
Thank you so much.
Well done. Well done. Well done.
Well done.
Thank you. Thank you all.
Thank you. Happy weekend to all of you. Happy Sunday.
Thank you, madam.
Thank you.
Thank you, sir.
Thank you, sir. Bye.